Welcome to the 13th session of our foundation course in palliative medicine. As communicated earlier, we'll be looking into the details of wound management today, and we have Sister Sheeba joining us to walk through the session. She's basically a staff nurse with around 18 plus years of experience and presently heading the clinical training department in Pallium, India. She is a certified trainer of NHSRC, the National Health System Resource Center of India, and she was recently awarded as the pioneer nurse of St. Christopher Hospice UK, the first hospice in the world. So it is indeed our pleasure and pride to have you with us, Shiva ma'am, today, and over to you.
Thank you, Sri Priya, for the introduction. Good evening to all. Happy to see you all. As senior said, today we are going to learn about wound management. You might have seen different types of wounds in your settings, but in palliative care, mainly we have seen two different types of wounds. One is pressure ulcer and the another one is fungating wound. So let me share my screen. So let's see what is pressure ulcer. Can anyone say, please, what is pressure ulcer? Please put your answers in the chat box. What is pressure ulcer?
Okay, bed sore is the best example.
Yes, bed sore is pressure ulcer or bed sore. I just asking what is bed sore. What do you mean by bed sore? The answers. Either you can unmute yourself and talk, or you can put your answers in the chat box.
Injuries to the tissues caused by prolonged pressure.
Okay, thank you. Any other answers? Okay, thank you. So pressure ulcer is a localized injury to the skin and other underlying tissue, usually over a bony prominence, as a result of prolonged unrelieved pressure. So if there is a prolonged unrelieved pressure there is a chance of getting pressure ulcer, especially on the bony prominence, but it can occur anywhere. Okay, so this is pressure ulcer. So let's see what is the pathophysiology of pressure ulcer. You can see a patient lying on a bed. If a patient lying on a bed, what happens? Because of the body weight, the bones are compressed. Because of the body weight, the tissues may not get adequate blood supply. So here you can see pressure for a long time. What happened? Because of the body weight, that bone weight, that will be compressing under the tissues. That time the tissues may not get adequate nutrition. So if the tissues may not get adequate through the blood supply, what happened? Tissue ischemia, finally stress and breakdown. So this is the pathophysiology of pressure ulcer. Sorry. So let's see what are the risk factors. So there are three major causes of pressure ulcer. One is, as we discussed earlier, there is one underlived pressure. Pressure is the one major cause. The second thing is friction, and the third one is moisture. These are the three major causes of pressure ulcer. So let's see what are the risk factors. So first is friction and shear. So these are the two major risk factors of pressure, friction and shear. These are the two major risk factors. So how friction is affected in the patient's skin? The thing is, for a bed-bound patient, so within the hospital, the nurses will be take care of the patient care, and nurses will be changing the bed sheets and all. When they go back, who will change the bed sheets? Usually, the caregiver will be changing the bed sheets. Nobody is there. The caregiver should do that bed sheet changing. So what happened? Usually, what they will do? So they pull the sheets under the patients. Their idea is good, but they need to change the sheets, but they don't know how to change the sheets. So that time, if they pull the sheets under the patient, especially on a bed-bound patient, there is a chance of friction between that bed sheet and the body. So that can cause some that tear or any some scratches or any peeling there. So if we don't know if there any peeling there or not, they don't know. So if you apply same pressure, same put the patient in same position for a long time, there's a chance of getting pressure ulcer. The second thing is shear. Shear means imagine on a obese patients, because of their the body weight, they are used to slipping downwards to the bed. So when they reback to their normal position, usually we call one or two nurses or caregivers or who are there, we call them to help. So when we try to reback to their normal position, we used to give more pressure. That time there is a chance of deep tissue injury. So if there is a deep tissue injury there, we don't know whether there is any deep injury happen or not. If you apply same that if you put the patient in the same position, there is a chance of pressure ulcer. And the next one is inward sensory perception and inward physical mobility. Here, what is that is here for a paraplegic patient, you can imagine for a paraplegic patient, they are not able to sense the lower part of the body. So that patients is easily get pressure. So especially on their sacral area and heel and toes. And the inward physical mobility. For a bed-bound patients, they are not able to move independently. They always depend others for the turning turn. So for example, imagine a paraplegic patients. After 2 hours, their upper limbs are okay, but they are not able to independently. So they need help. So they will, even if they need to change the position, but they don't able to, they can't. So they that type of patients can get pressure ulcer easily. And altered level of consciousness. The unconscious patient or semi-conscious patients are the risk group patients. And fecal and urinary incontinence. Here I already said moisture is one of the major risk factor. Here, if the patient is having fecal and urinary incontinence, there is a chance of continuous moisture. So that type of patients can get pressure so easily. And malnutrition and dehydration. Here, if there is a malnutrition there, so lack of protein intake in their diet can cause pressure formation and dehydration also. And the final one is excessive body heat and advanced age. These are the major risk factors of pressure ulcer. So come to the common sites of pressure ulcer. So it can occur anywhere, especially over the bony prominence, but it can occur anywhere, depends on the patient's position. Even if the patient is on wheelchair also, the patients will get pressure ulcer. You can see some images that for the different size can occur, develop pressure ulcer, heel, occiput, scapula, toes, sacrum, these all the areas. So from this picture, we have to understand that it can occur anywhere, depends upon the patient's position. So come to the common sites. So if the patient is, this is the most common position. If the patient is on supine position, these are the major bony prominence: occiput, elbow, sacral region, heels, scapula. So and toes are the major pressure point areas. So why I am telling these all point is, so after 2 hours or after 2 to 3 hours, we have to change the position from supine position to left lateral or right lateral positions. When we change the patient from supine position to right lateral or left lateral position, you have to give a special attention on those areas. You have to give whether special attention, whether there is any color change or not, is there any peeling of the skin. These all things you have to check. See, if the patient is on side lying position, ear, acromion process, ribs, greater trochanter, medial and lateral candials, and lateral condyles, these are the major pressure points. The thing is, if the patient is on side lying position, there is a chance of friction in between the knees. So there is a chance of the knees are rubbing together, and there is a chance of developing pressure sore in between the knees. If the patient is lying on side right lateral position or left lateral position, you have to keep a small pillow or a folded sheet in between the that knee, so that we can able to prevent friction. You can see here, there is a here there is a chance of developing pressure sore in between. Always you can keep a small pillow or a folded sheets in between the knees, so we can able to prevent friction for that area. And come to the Fowler's position. Here we all know that this is the good position for dyspnea patients. Head, shoulder, sacrum, buttock, ischial tuberosity is the major pressure points. Even if the patient is on Fowler's position also, we know we are not able to to put the patient in supine position or right lateral position or left lateral position. But even if even if the patient is in Fowler's position also, you have to give at least 10% position change is mandatory. So you have to turn at least few, then maybe 10-degree position, not put the patient in supine position or right lateral or left lateral position. And come to the prone position. Here also, these are the major the pressure points. Yeah, whenever you have seen a bedbound patients, you have give a special attention on pressure points, and also you have to give a proper instruction to the caregivers too. Is there any whenever they change the patient position from supine position to right lateral position, or right lateral lateral position to Fowler's position, or whatever position they give, whenever they change, they have to give a special attention on their pressure points. And come to the stages of wound. There are 5 stages of wound. The first stage is non-blanchable erythema. Okay, so if you see this type of stage, if you change the position from the supine position to lateral position, if you have seen this type of color changes there, you have to give special attention on that area. Okay, so I'll come to the management later. So if there is a non-blanchable erythema there, see, if you put a finger pressure, your own finger pressure on that area, that redness will be there. It's not blanching. So this is the first stage of pressure ulcer. So come to the second stage. If you are not gave a that special attention on that pressure, stage 1. So there is a chance of damage of the dermis layer. So here is a shallow open ulcer into the dermis or blister formation. If there is a blister formation there, definitely the skin will be breakdown. This is the second stage of pressure ulcer. So come to the third stage, the full thickness ulcer. All subcutaneous layers will be affecting, and sometimes tunneling will be there. So tunneling means the narrow opening or passageway that can extend in any direction through soft tissue. When you do the assessment, you have to give a proper assessment for the wound. So if there is any tunneling in the wound, you can give a special attention to the patient, that wound area. Otherwise, that wound won't be able to properly heal. So you have to give a special attention on that tunneling part. This is the third stage, pressure ulcer. So come to the fourth stage, exposed muscle, bone and tendon. It look like this. So all muscle, bone and tendon will be exposed. You can see like this. Sometimes tunneling will be there. So you have to do the proper assessment on that. And come to the unstageable. This is the fifth stage. This is an unstageable wound. So if there is a scar, it's a black necrotic tissue on the top of the wound, we can assess the stage. That is called unstageable wound. Okay. So when we document it, you have to document it is a unstageable wound. Okay. Once you remove the stuff from the top of the skin, then only we should know how much layer is affected, whether there is affected in the subcutaneous tissue or exposed to the muscle or tendon, like that. So if you see this type of wound, you have to document it is an unstageable. So there are 5 stages of wound. The first stage is non-blanchable erythema. The second stage is dermis layer will be breakdown. The third stage is full thickness ulcer. The subcutaneous layer fully affected. And the fourth stage is muscle, bone, and tendon will be affecting. The fifth one is unstageable wound. So there is we are not able to stage the wound, that is unstageable wound. So come to the assessment part. Doctors and nurses should assess the skin at each visit of a bedbound patient and a wheelchair patient. Whenever we see a bedbound patient or a wheelchair patient, we have to give a special attention on the pressure points, on their pressure points. So what are the things you have to assess? Assess the pressure points. Okay, we already discussed what are the important pressure points. You have to give a special attention on those areas. And the second thing is assess pain associated with wound. If the patient is having wound, for example, if you see a patient with a stage 3 pressure ulcer, so that time you have to ask whether the patient is having pain or not. You have to give a pain medication. If the patient is complaining of pain, you have to give a proper pain medications before doing the wound management. And assess the location of the wound, measure width, length, and depth of the wound, stages of wound, and presence of exudate. Exudate means oozing out of fluid from the wound. So yeah, you can assess for that and assess for tunneling also. All data you have to document it properly. So then only we have to after 2 weeks we have to know whether our treatment is effective or not. So after 2 weeks, you have to do the proper assessment like this, and then you can find out whether your treatment is good or not. So you have to do the proper documentation after assessment. So come to the management part. Always medicate the patient for pain before wound care. So if the patient is having pain, you have to give a proper analgesic sign. Wait for some time, and after that you can give a dressings to the patient. And if the patient is having stage 1 pressure ulcer, you have to teach the caregivers about the turning techniques and the excellent incontinence control. So as I said earlier, unrelieved pressure and the moisture is the 2 major causes of pressure ulcer. So here, if there is a stage 1 pressure ulcer there, they always keep the patient in the another position. Like if there is a sacral area, non-blanchable erythema there, they can put the patient either right lateral position or left lateral position. Our idea is you have to give that pressure relief, that area you have to leave it free. So if if the patient is having stage 1, you can give a special advice to the caregivers. So about the turning techniques and also moisture control also. And the second stage is damage. The dermis layer is damaged. So that time, so you have seen that picture, there is no pus or no discharge, only clean wound is there. So that time, normal saline, you can clean the wound with normal saline. That is enough for that second stage of wound. The come to the third, fourth, and fifth unstageable wound. If there is a slough there, black necrotic tissue there, you can do the surgical debridement. Okay, and before you're doing the surgical debridement, you have to make sure that whether the patient is pain-free or not. If they have pain, you can give pain medication and use normal saline for wound cleaning. Always you can use normal saline for wound cleaning, and you can teach homemade saline preparation too. I'll come to later how to make homemade saline. If there is a water or infection there, you can apply metronidazole powder. You can take metronidazole tablet and crush it, make it a powdered form, and mix with white petroleum jelly and spread to the wound. So that can help to reduce the infection, and the white petroleum jelly will give the moisturizing effect to the wound. And also you can use depredise ointment. If there is a slough there, you can apply the depredise ointment. And after, if there is no slough but the wound is deep, you can that time you can use Bagagi. But if the patient is not affordable, we can't advise the patient for using these type of medications, but they are not able to buy. This is quite expensive. So that time you can suggest metronidazole powder. And charcoal. If the patient is having that wound is that coming with the foul smell, lot of foul smell there, you can advise the patient to put charcoal piece. Yeah, the charcoal piece. Nowadays, the charcoal dressings also available, but the thing is that quite expensive. If the patient is affordable, you can suggest for that. Otherwise, they can take the charcoal pieces and keep under the bed of the patients, and that will help to absorb the bad smell. And avoid hypochlorite solution like povidone iodine and hydrogen peroxide for cleaning this type of wounds that will destroy the granulation tissues. So always you can use normal saline for cleaning. And also you can do one thing, surgery consultation. If the patient health status is okay, but stage 4 that pressure ulcer there, you can refer the patient to the surgeon and see whether there is a skin grafting procedure is possible or not. So you always think like that too. And the next one is negative pressure wound therapy. With the help of suction apparatus also you can do this treatment. If you do the negative pressure wound therapy, that will help to suck out all the exudate from the wound. That will help promote healing. And also because of the continuous pressure to the wound, that will stimulate the blood circulation and start healing. And come to the homemade saline preparation and dressing supplies. Usually the palliative care settings will be giving the dressing materials, but if the dressing materials are finished, what they will do, you have to teach some home remedies too. So as I mentioned earlier, you can suggest the patient, you can advise the patient to use homemade saline. In the hospital, we have a normal saline bottle. Sometimes when they go back, they are not able to buy that the injection normal saline bottle and all. So that time you can suggest, you can instruct the patients how to make homemade saline. So they can take 500 ml of water and add 1 teaspoon of salt, boil it, cool it, and keep it covered. So that solution they can use for cleaning the wound. Here, this is not a surgical wound. Wounds are these type of wounds are not sterile. You have to keep the wound clean. So here is a clean saline is enough for cleaning this type of wound. And also you can suggest advice for some dressing supplies. Take cotton sarees or a dhotis and cut into squares, and that cotton pieces, they can steam it half to 1 hour, and then if they want, they can apply Vaseline on the cotton pieces, and after that they can steam it well, and then they can use for dressing. Come to the prevention part. We all know that prevention is better than cure. Whenever you see a bedbound patient, you have to teach the patient about the prevention of bed sore, and the caregivers about how to prevent bed sore. Here, position change is the major thing. If they, every 2 to 3 hours, they have to change the position, and every 15 to 20 minutes for a wheelchair patients, they have to relieve their pressure every 15 to 20 minutes if the patient is on wheelchair. And manage incontinence. So incontinence control is also very, very important. If they having urinary incontinence, if the patient is willing to put a urinary catheter, you can put a catheter. But if they are not willing to put a catheter, you advise the caregiver to use diaper. If they are not affordable, they can use their own clothes. But the thing is, if there is any moisture there, they have to change the sheets as soon as possible. And the special surface like air mattress and water mattress, you can suggest either air mattress or water mattress, but air mattress is the good one. But when you suggest air mattress or water mattress to the patient, they might be thinking that if you when they put the patient on air mattress or water mattress, that both mattress will look after everything. So whenever you suggest these type of matters, you have to tell the caregivers about the importance of position changing, because this is not 100% preventable measures. They will, these two type of matters will help to relieving the pressures. Okay, so if the patient is on air mattress also, if you are not change the change the position, then the patients will get pressure ulcer. So that important message you have to convey to the caregivers, and they can use adequate pillows and cushions for the patients too, for the pressure points. And nutrition, hydration and exercise. So nutrition, lack of protein intake in their diet can cause pressure ulcer. So you have to instruct the caregivers and the patient about the importance of nutrition and hydration and exercise also. If they are not able to do their own exercise, you can encourage the caregivers about the passive exercise. If they do the exercise, that will help to improve the circulations. That way we can able to prevent pressure ulcer. And whenever they change the position, they can give a special attention on pressure points, and after that they can take a white petroleum jelly or any moisturizing cream in their hand and give a massage, the simple massage on their that area, especially on the pressure points. So that will help to improve the blood circulation, and that way we can able to prevent pressure ulcer. If liquid paraffin or white petroleum jelly is not available, they can use coconut oil. And always provide wrinkle-free bed. If the wrinkles are present in the bed, that can cause pressure ulcer. Always they will they should provide wrinkle-free bed and nail care also. So if there is if the nails are too long, that patients scratch their own skin, and if you give a pressure on that area, there is a chance of getting pressure ulcer. So here is a small tip. You can keep it in your mind. Double SKIN. Whenever you see a bedbound patient, you have to keep it these double SKIN. The first S is supporting surface. You have to make sure your patient is getting relief on proper surface. Okay, you can suggest that air mattress or water mattress for that patient, at least, or a soft mattress also you can suggest. And the second S is skin inspection. So whenever we turn the position, you have to give a special attention on the bony prominence. The next one is K. K is keep moving. Every 2 to 3 hours, they have to change the position. The next one is I, incontinence or moisture control. So So if there is a bladder and bowel incontinence there, they have to give a special attention on that area. Whether there is, if they are willing to put a catheter, you can catheterize the bladder, or they can use diaper. And the last one is N is nutrition. So nutrition, hydration is one of the major part. So always you have to instruct the patient about the nutrition and hydration also. Okay. So we all know that without a caregiver, go back to their own home. We can provide home care to the patients, but the caregiver is the best. The one, only one person can look after the patient. So we have to give a proper instruction to the caregivers, and we have to understand that without the caregiver support, we can't do anything for the patients. We need a good rapport with the patients, how to engage the patient family with especially family for involving the patient care. So we can develop a contract of care, like so instead of using you, we can start the use the word we. So if we use the word we, they feel more comfort, and so they'll start to open more things and all. So yeah, always we use the term you should turn the position, you should give adequate nutrition to the patients, you should give massage, like that. Instead of you can start the word use the word we. So that time in my 18 years of experience, I have a lot of experience. If we use the word we, they feel more comfortable, and they will ask too many questions. If they have any doubts, they'll ask that time itself. And also they will call me and talk to me freely. So if we use the word we, so they feel, in my experience, I feel more comfortable, that patients feel more comfortable if you use the word we. So that way we can try to engage the patient family in the patient's care. And also you can provide patient information leaflets too. So like this, this is the Malayalam leaflets. Like this, you can provide this your own language to the patients. That will help the caregivers to look into, and if they have any doubts and the position changing, that the turning techniques and all, so they'll go and look that leaflets, and then that will help to care more the patients. They'll get give a good idea about the patient care. And we have a video. We'll watch the video and then move on to the next part for preventing, how to preventing pressure ulcer. I hope you have get a good idea about the prevention of pressure ulcer. So okay. So next move on to the fungating wound or cancer wound. I think you might have seen in your settings that cancer wound. So what is the difference between the pressure sore and the fungating wound? Is there any difference? One of you can unmute yourself and talk.
I think in the pressure wound, infection is not. Most of the time, infection not.
Most of the time, infection in the pressure ulcer or
infection won't be there. Most of it is a dry wound, no?
Where ma'am? Pressure ulcer.
Pressure ulcer, especially
Pressure pressure ulcer is a dry wound. This is infected wound. That is, what do you mean? Okay. Any other answers? Any other answers? I am waiting for your answers. No difference?
Pressure ulcer could be other than the site of the cancer, where on the bony prominences, the cancer wound likely to be at the site of the origin of the cancer area, where the skin erodes along with bleeding, pus discharge
Okay.
to the pressure.
Okay. Okay, sir. Okay. Any other answers?
We have a response.
Eh?
Fungating can be anywhere, not necessarily in the pressure points.
I'm getting on this. Okay. Continue.
Cancer and inverted in cancer and necrotic tissue in fungating wound. These are the two responses in the chat.
Okay, ma'am. Thank you.
The fungating wound.
So that means no necrotic tissue in the bed sore. So bed sore is also we have the necrotic tissue. No, there is slough. So thank you for the answers. Here we have to understand that pressure sore is preventable and curable. This is not preventable and not curable. So this is the major difference between the pressure ulcer and the fungating wound. So let's see what is fungating wound. Fungating wound is a primary or secondary malignant growth in the skin which has ulcerated and difficult to heal. Okay, so once the fungating wound develops, we can not able to cure properly. It's difficult to heal. It's not cured properly. So it refers to a malignant process involving both ulceration and proliferative growth. So and it looks like a cauliflower in shape and a nodular fungus in shape. So that is why we call it as fungating wound. So not because of fungus, it looks like that nodular fungus shape on the cauliflower in shape. So come to the pathophysiology, usually there is a development of non-tender skin nodules first, that gradually that skin nodules will be enlarging, and after that when the skin nodules enlarging, what happen, that leads to disruption of capillaries and lymph vessels will be there. If there is a disruption of capillaries and lymph vessels there, altered coagulation and disorganized circulation, finally tissue hypoxia and necrosis. This is the pathophysiology of fungating wound or a cancer wound. So come to the Marjolin ulcer. Have you heard about Marjolin ulcer? This is a type of malignancy of the skin. Malignant changes in the chronic wound like burn scar ulcer, pressure ulcer, and venous leg ulcer. So that pathophysiology is a little bit different. Appearance of small mass in the wound, not previously present, and after that, the patient will be experiencing pain, and the character of the skin, that wound, the character of volume, appearance, and all will be changing. So if these changes there, you can refer the patient to the oncologist and take a biopsy and find out whether there is any Marjolin ulcer or not. If there is a Marjolin ulcer there, you have the patient should take a proper treatment. It's a curable cancer. They can get proper treatment for Marjolin ulcer. Okay. So if these changes there, refer the patient to the oncologist and take a biopsy and find out whether there is any Marjolin ulcer or not. So come to the problems. We from the beginning itself, we understand that palliative care is not only for the patients, it's for the family also, and also it is a total care. So here is a non-curable ulcer. Here, these patients can develop physical problems, psychological problems, social problems, spiritual problems. So what are the physical problems that can the patients can get? So these are the physical problems. The first one is pain. So how does it happen? So because of the direct exposure of the dermis, and the second thing is that tumor will be compressing on the blood vessels and nerves. So that time the patients will that experience two different types of pain, because nociceptive pain and neuropathic pain. If the tumor will be compressing on the blood vessels or nerves, can cause neuropathic pain, and the direct exposure of dermis can cause nociceptive pain, and the improper dressing changes. Usually the dressings are adherents to the wound. So without properly soaked, when we try to remove the old dressings, there is a chance of developing pain. So these way the patients will have pain. And the second one is malodor. So here, devitalized necrotic tissues there that can cause malodor, because of the anaerobic bacterial infections can cause a lot of smells, and because of necrotic tissues. And the second thing is stale exudate dressings have been have been in place number of days, can cause malodor. And bleeding is sometimes that the tumor will be protruding the major blood vessels. And the next thing is improper dressing techniques can cause bleeding. And exudate, sometimes that usually lot of that purulent discharge and watery discharge coming from this type of wound, because of that the internal itself, it's that wound itself, increased permeability of the that blood vessels within the tumor can cause exudates. So we need to manage exudate well for this patient. And itching is very rarely itching will be there, because usually the origin of small nodules, the margin from the margin of the wounds can cause that, leads to chemical reactions that can cause itching. And the another thing is that discharge will be touching the normal skin can cause itching. And infestation with maggots. So how does maggots come? Can anyone say how does maggots come? Any answers?
Nothing in the chat. I'm waiting for responses.
Okay. Any idea?
Dr. Jennifer is telling flies.
Okay.
House
Sir.
flies.
Okay. Thank you, sir. You are correct. So it comes from house flies. I'll come to the management later. So if there is a wound there, usually the house flies are attracted with the infected wound, so that the house flies may lay the eggs, and that can cause maggots. So always try to educate the patient and the caregivers about the proper covering of the wound for preventing maggots. And communication difficulties too. If the patient is having head and neck cancers, they are not able to communicate properly. Even if they have physical problems, they are not able to communicate properly. What you can do is, if they are able to write down their problems, you can give a sheet of paper and ask them to write down their problems. So then we can get an idea about their problems, and we can able to treat their problems well. And come to the psychological part, here altered body image. So this is one of the major problems. You can imagine the one wound in that patient's face, that huge wound. So that can cause emotionally and socially also, that feel the patients, affect the patients emotionally and socially. And sexuality also. sometimes misconception about the disease can affect their on sexual life, and denial. Sometimes that negative denial will be there. The patient won't be accept the disease, and sometimes the disease progression is is very bad progression there, but the patient is on accept the progression. So they always said like that, no, no, my wound is healing well. If you ask, what do you think, what do you understand about your wound that right now? So so is there any problem there? Is there any do you think to that wound size is large? So sometimes they may tell, no, 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 my wound is coming that the heel. So that last week, after 2 weeks, that wound is healed properly, something like that. So sometimes denial will be there and fear will be there. So some patients will be thinking like that, what happened next? Some sort of fear will be there if they have an experience in their own family, like maggots formation in the these type of wounds there. They always have a fear inside their mind. So might be maggots will be coming. They don't know how to maggots come. So that types of fear will be there. If there is a bleeding history there from the wound, they might have fear like that. Maybe bleeding can maybe if there is that type of bleeding can come or not. That type of fear will be there. And finally, anxious. They will be always anxious. What is next? What is going to be next? That type of anxiety will be there. And also, if the physical problems is not controlled well, they'll go to depression too. So we have to do the proper assessment, and also shame will be there. They always feel guilt. And come to the social part, family isolation will be there. If a person get yeah, this type of illness in one family, the family can choose the corner side room and keep the patient there. So they are not allowed to come to the kitchen and or in front of the room and all. So they always keep the patient there only. And social isolation. So that will affect the patient emotionally, because nobody is willing to see this type of patient, because maybe friends, relatives, neighbors are not willing to see this type of patients, because maybe because of their misconception of the disease, and social stigma will be there, fear of contagion will be there, and effects on family. It will be affecting the sexual relationship and marital disharmony. So nobody is willing to get married from this type of family because of maybe misconception, and maybe they might be thinking like that hereditary factor and all. So this will be affecting the patient emotionally and socially. So these are the things you can keep it in mind when we assess it. And spiritual problems too, problems also. So always they may be thinking like interference with religious rights. They used to ask us because of my sin, the God punished me like this. These type of questions they usually ask us. So what we can do is, you can do the proper assessment. And when we do the assessment, if possible, you can do the individual assessment in front of the caregivers. Nobody is telling the truth. So we have to keep it in mind, and whenever possible, you can do the individual assessment. Then only you will get a proper idea about the patients, who will take care of the wound, whether their caregiver is give a proper support to the patient and all. So you have to give, you can take it the history from the from individual case history. And come to the assessment part, wound locations. Always you can do the assessment of, is there any mobility impaired and easily covered with a public view. So these all things you can assess. And wound appearance surrounding the skin also, and potential for complications. Is there any potential for complication like head and neck cancers? There is a chance of bleeding. So where so if there is a bleeding, the profuse bleeding, If there is a major blood vessels protrude when they are in the home, so how will they manage? If there is any potential for complication there, you have to prepare the patient family before that. If there is a bleeding there, how to manage bleeding in their home. And come to the management part. So always try to relieve the symptoms. The palliation of symptoms is the principles of management of wound care. If the patient is having pain, you can try to reduce the pain. And if they have a odor or infection there, you can try to reduce the infection and manage the exudate also. You always there is a lot of exudate, the oozing or pus discharge from the coming out from this type of wound because of that hyperpermeability of the blood vessels within the tumor. So we have to treat well, and we can manage well and minimize bleeding also. Always give education to how to minimize bleeding before removing the old dressings. They have to give a proper soaking, and then they can try to remove the old dressings. That way we can able to prevent bleeding and pain. Holistic care is a total care. Total care is mandatory for this patient. So this patient so having physical, psychological, social, emotional, spiritual problems there. So always you have to give a total care this type of patient, and empowering the patient and family in wound care. Always try to involve the caregivers in the patient wound care. And what are the criteria for wound care? So our goal of care is to maintain or improve the quality of life of the patient through symptom control. So if the symptom is controlled, so the second main aim of palliative care is to relieve pain and other symptoms. If you give a proper symptom control to the patient, that way we can able to improve the quality of life of the patient. So here also, if the patient is having symptoms, you can try to reduce the symptoms. So here this patient need an empathetic care. So you have to keep your place in their own shoes, their place, and you have to always try to provide an empathetic care to the patient, and provide thorough bath before dressings if possible. So if the patient is able to do bath, you can instruct the patient, encourage the patient to take a thorough bath. That way we can able to or if they take thorough bath under running water, so the all necrotic tissues, so this type of wounds, all necrotic tissues will fall off. So here this type of wounds are fragile. So here this type of wound have lot of necrotic tissues. So if they are able to take a good bath under running water, that all necrotic tissues will fall off. After that, you can do a thorough cleaning with the normal saline and do the dressings. And before you are doing the wound dressings, you have to make sure that whether the patient is pain free. So if they are having pain, you have to give a proper analgesics before wound dressings. And if you are using systemic analgesis, you can wait for another 45 minutes and see whether the patient is having adequate pain relief or not. Then you can do the pain wound dressings. And selected dressings depends upon the wound, that exudate and the wound condition. So how to minimize pain? So as I said earlier, there are two different types of pains will be there for this type of patients. If there is a deep pain like the nociceptive pain, there you can adjust the systemic analgesics. Here, for example, if the patient is having morphine, that 10 milligram 4 hourly, so when you go for a home visit for dressings, if the patient is having pain, you can give a rescue dose and wait for 45 minutes, and then you can do the dressings. And all other analgesics also you can give for control the nociceptive pain. But the systemic analgesics, if they that will not help for the neuropathic pain. So that time you can give a local anesthetic agent like sensorcaine or that's xylocaine. for local application. If there is a nociceptive pain there, it's a superficial burning, pricking type of pain there, you can apply, give some local anesthetic agents. Then wait for 10 minutes and then they will get adequate pain relief. Then you can do the dressing. So come to the malodor management. So always daily advise the patient caregivers about the importance of cleaning and dressings. Daily dressing change is mandatory for controlling malodor. As I said earlier, stale exudate dressings have been in place in number of days and cause malodor. So always try to change the dressings every day. Depends upon the wound condition. If there is a drainage, that huge exudate there, they have to change the dressings in between two. And local metronidazole. You can take a tablet and crush it powder, and that powder they can apply. And this is one of the good agents for controlling anaerobic bacterial infection. Taboo metronidazole or injection metronidazole, and also you can use injection metronidazole for irrigation also. There are a lot of pocket formation inside the wound, so this will help to reduce the infection. And also you can try one course of systemic antibiotics. It may not help fully because the superficially that blood supply is not adequate, but you can try one course of antibiotics. And also you can continue tab metronidazole orally on daily in 2 weeks, and then you can continue if the patient is not if the wound is not controlled well, you can continue the metronidazole tablets, oral tablets. And frequent changing of dressings based on the wound conditions, you can suggest the patients. Here also no hydrogen peroxide betadine. This will irritate the wound, and this will not help for these patients. Please avoid this type of cleaning solution for this type of wounds. Come to the bleeding part. Always try to prevent bleeding. As I mentioned earlier, dressings are adherence to the wound. Try to soak before removing the old dressings. Soak well with normal saline or that cool water. Then they can remove it and apply. Once sometimes bleeding there, they can give local pressure, and if not controlled, you can apply sucralfate powder. That the sucralfate tablet has a sealing effect. That crushed it, tab sucralfate, crushed it and powdered, make it a powdered form and apply on the bleeding area. And also you can go for tranexamic acid and then systemic ethamsulate too. If they are not helpful, you can go for systemic ethamsulate and palliative radiotherapy. If possible, you can, if the patient's health condition is okay, then you can refer the patient to the that oncologist and see whether the palliative radiotherapy is helpful or not. So these all things will help to strengthen the size of the tumor. And so the few maybe months or months they will save. So that will help to strengthen the tumor size. And if there is a bleeding there, you have to, especially head and neck cancers, there might be the chance of bleeding any time. So we have to prepare the patient family. Whenever the bleeding there, they have to use dark color cloth for wipe out the blood. So this is very, very important. This way we can reduce the anxiety and anxiety level of the patient and their family too. So always you have to educate this for the caregivers. And role of cancer therapy. So radiotherapy, cytotoxic chemotherapy, hormone therapy, and surgery, debulking surgery. If possible, you can send the patient for debulking surgery. And radiotherapy, cytotoxic chemotherapy, and hormone therapy. These will help to that strengthen the size of the tumor. That way we can able to prevent bleeding. Come to the maggots part. So always try to prevent maggots, as one of you mentioned, it come from flies. So whenever we see this type of patient, you have to give a proper education to the patient and the family about the covering of the wound. So they can use mosquito nets and all. They have to maintain a personal hygiene, and if there is a maggots there, they can apply not take a turpentine into the gauze piece and squeeze well, and then that will close give that uh, give close to the wound, so that will that time the maggots will come out. So they keep close to the wound, that is enough. That time the maggots will come out. So physical removal is the only way to remove the maggots from the wound. So here, one important message I want to share with you is, don't follow maggots. When the maggots come out, you have to take it out with the help of maggot that artery forceps. If you usually the maggots will come out when you go with your artery forceps, they go inside. So if you follow maggots, what happen? Your artery forceps will damage the blood vessels. So don't follow maggots. When they come out, you can take it out, put it in the that hot water and discard in the toilet. So so this way we can able to manage maggots. And here educate the patient and family for proper covering of wound is very, very important. So thank you. Any questions there? Like to answer.
Thank you, Sister Sheeba. We'll quickly take a few questions before case presentation, maybe 2 minutes. Are there any questions right now? Yes, Dr. Shweta, please go ahead.
Changing the patient's position, I was reading some articles which said that don't turn 90 degree, meaning in the lateral position, maintain it between 30-45 degrees angle. So is there any basis to that, or meaning turn the patient by 30-45 degree, give a soft pillow support or something on the backside, rather than putting full 90-degree turn, which will cause further pressure on one side? No?
Yeah. Yeah, ma'am, we can't put the patient is 90 degree always. Whenever we change the position from supine to right lateral or the left lateral position, so maybe 45 degree. When we turn the patients, definitely we won't be able to keep the position that 90 degree position. We won't be able to keep the position. So we always give a comfortable position to the patients. So so whenever we change, you can just think we that upper hand, or we can give a proper supporting surface to the pressure point areas. So we no need to give a 90-degree position to the patients. Our idea is to change the position to relieve pressure. When you at least 10 degree, the turning is mandatory. Ma'am, do you want to add anything?
No, the same thing. No. Just that when you try to keep pillows under the one surface, what happens is that patient just starts lying down on that pillow. You just turn 45 degrees and then you keep pillows, they just lie down onto that pillow. So the pressure is not relieved. So just that, make sure pressure is relieved, at least for 2 hours. That's it.
You said something about application of turpentine, no? Sister Sheeba. Yeah, that is available in medical shop, that turpentine, or same
yes.
as
Yes, medical shop is available, ma'am.
Yes, Dr. Ravi, you have a question.
Yes, ma'am. In some cases where in bony meds like pelvic med, spinal cord compression, or this thing, the patient tilting to one side makes them very discomfort, and they lie only on the same supine position. In such cases, advising them to tilt to the other sides makes them more painful, and it becomes challenging to avoid pressure ulcers in those patients. So how come we address to such situation?
if there is a spinal cord compression there, the patient is that type of patient there, not need to complete turning. So no, here you can put, if you can see this is my telephone. So this is the supine position. We always keep the, if the patient is having spinal cord compression, we used to keep the patient the supine position. So no need to turn this. This is the sideline position. You can give the small pillow here, that small pillow here, and or after 2 hours you can turn like this. This is enough. Okay, not need to give sideline that or put the patient is right lateral or left lateral. You can give at least a 10-degree pressure relief.
Thank you.
Okay.
We'll quickly go to the case presentation and we'll take up the questions after that. Dr. Srikanth, you had a question. Can you unmute from your end?
We see a lot of spinal cord injury patients acutely as well as chronically. When they are acute and we prefer log rolling, we have a maneuver where the nurse and 2 attenders, they move the patient together so that there is no segmental mobility at the unstable part. And through that way, we maintain position. And in spinal cord injury, we prefer to prop up with pillows, and 30 degrees of side lying with one leg flexed and the other extended helps a lot. And in cases in chronic injuries in the sacral ulcer, sometimes we put them prone as well for a long time. We have prone mattresses where we have cutouts for the genital region as well as for the knees. And some of them, I mean, it's not very comfortable, but when we really have to, when the ulcer is the main thing, is infected, prone lying also helps a lot. And there are pressure relieving mattresses as well, where the frequency of position change can be done once in 3 to 4 hours instead of every 2 hours. So that helps to some extent. I just wanted to add those aspects.
Yes. Always try to use air mattress for this type of patients.
Thank you, Dr. Srikanth, for the inputs. Yeah, I think we do log rolling when they are in the IP, but then when they go home, that's very, very difficult to get the support. Like there'll be only one person at home. So then the focus shifts from training them how to do it on their own. If there is you can't expect more than one. One is some maximum that you can expect. So it's about training them how to do it on their own with minimum support.
Once they go home acutely, usually for a few days they'll be there, then we give these orthoses, and then after that once they go home, there's no need for log rolling, and we teach them bed mobility where they should be able to move on their own. In fact, one person also not required for low level injuries.
Yes.
Even high level tetras are able to change position to some extent. High level para, sorry, not tetras.
Yeah, very true. But the key is that to train the caregivers. Otherwise, they don't have any clue where to touch, how to, and they put in a lot of pressure, and a lot of effort. They get tired. So maybe simple step, as you said, one roll, one leg flexed makes it easier to change the position. So these are the things. Thank you for your input. So these are the things I think we need to talk to the caregiver so that it makes it easier for them to manage at home. Thank you, Dr. Srikanth, and we'll start the case presentation and we'll go on to further discussion. Dr. Anit?
Yes. Good evening, all. I'm Dr. Anit Catherine, currently working as a senior resident in the Department of Physical Medicine and Rehabilitation in St. John's Medical College, Bangalore. So today I'm presenting a case of a 20-year-old female who presented with diagnosis of non-traumatic tetraplegia secondary to anterior spinal artery thrombosis with neurogenic bowel and bladder, and also with multiple pressure ulcers. So she presented with weakness of bilateral upper limb and lower limb with sensory impairment, multiple pressure ulcers with fever, and with loss of control of bowel and bladder and tightness in bilateral lower limbs. Next slide, please. Yeah. So she was a BBA student, presented with sudden onset of weakness in bilateral upper and lower limbs over 1 hour, And she also had loss of sensation below the level of the neck and breathing difficulty also. The MRI spine was done and it revealed anterior spinal artery thrombosis. She was initially admitted in ICU with mechanical ventilation, and in view of prolonged ventilation, later on tracheostomy was done, and gradually she was weaned off. And she was also put on a Foley's catheter for her bladder management. And this patient developed pressure ulcers during the stay in the ICU. So once she was medically stable, she was discharged to home, and there was a partial improvement in the motor and sensory component after 8 months. And also she was able to sense her bowel and bladder, but there was no control. And there is also, on admission, there is also a history of recurrent urinary tract infections. So on examination, patient was conscious and oriented. She was febrile, pulse rate was 120 beats per minute. Respiratory rate was 20 and BP was 100/70. Other systems were within the normal limits. Next, please. So she was on a tracheostomy tube, Foley's catheter. Her bowel was loaded and she also had a sacral pressure ulcer, stage 4, a stage 3 right ischial pressure ulcer, and a stage 4 right trochanteric pressure ulcer. Next, please. And so her muscle powers in the upper limb, elbow flexors was normal. Again, elbow extensors, one side was 3 and other left side was 4. Wrist extensors was 5 out of 5. And finger flexors only on the right side, she had only a flicker of movements, and lower limb, there was no powers. Next slide, please. So on examination of the pressure ulcers, there was active purulent discharge present, slough was present, bone probe test was positive, necrotic tissues was present. So on admission, we did her baseline investigation. So her HP was 11.7, total counts was increased. In view of fever spikes, and the patient is also having like pressure ulcer, and she is also on a intervening catheter. So to rule out urinary tract infection also, we have done a urine routine. There was also some UTI. So we also did a culture. And from the pressure ulcer also, tissue culture and sensitivity was done. So in the treatment, ma'am, next slide. So in the treatment, we started with spinal cord injury education to the patient. We counseled and educated the patient regarding what are the complications which can happen in her, what are the prognosis, everything we counseled. And also we taught her the pressure ulcer, how it is happening, how we can prevent it, even if how to do the pressure ulcer dressings, how often the pressure like position need to be changed. Everything was taught to the patient. And for the bowel management, a proper bowel program was taught to the patient. So her UTI was also treated. And there was hip adductor spasticity, which was intervening with like self-care activities. And also we found it is difficult to position in here. So we treated the hip adductor spasticity with antispastic medications, and also with obturator nerve block. Next, please. And initially bedside debridement was done. And also the family members were taught how to do a bone dressing. Next, please. So finally, once she was aware, like once her pressure ulcer score, we usually assess the pressure ulcer score of the patient before we take the patient to OT. Basically, we will ask a certain, there is a made questionnaire. We will assess how much they know about the pressure ulcer or how it is happening, because we don't want that pressure ulcer happening again once it is surgically managed. We don't want the patient going back how she came to hospital. So we will assess the pressure ulcer score, and also we will advise for prone lying. So once patient is like comfortably, she could lie prone lying 24 hours in a day, and with all activities done in prone lying. And like pressure ulcer score was also good. We have taken her to OT, and we did right ischial and trochanteric pressure ulcer debridement, and primary closure was done. And sacral pressure ulcer, we did debridement, excision, and also gluteal rotation flap under LA. For gluteal rotation flap, we also took help of plastic surgeons. And later on, after 3 weeks, we progressed with hip and knee flexion activities, sitting were initiated, and pressure relieving techniques were taught to the attender. And also adaptive devices was given for brushing, eating, grooming, typing. and she was able to write with an adaptive device. Our social worker has also provided her a laptop since she was a BBA student, because hand function was not adequate to hold a pen and write things herself. So we gave an adaptive device which she could use for typing. And she was mobilized in a self-propelled wheelchair at the time of discharge. And she also joined back to the college. So during the time of discharge, patient could shift herself to a wheelchair independently. She could do most of her self-care activities. Everything she was independent. Only when coming to the lower body, certain aspects of it, she needed help. Next slide, please. So psychosocial aspects in her case, she's a 20-year-old young female who is a studying student. She had a lot of worries about whether she can continue her studies, and they were financially from a poor background. And patient was also initially very depressed. Main thing was the worrying thoughts was about her future. And the positive factor was like the family was very supportive. So the concern was pressure ulcer, her education, and also main thing was for she being dependent for all her activities. To summarize, a tetraplegic 20-year-old female with a multiple pressure ulcer or the right ischial, right trochanteric, and the sacral region. And as the discussion points, I think we need to discuss more like why pressure ulcers are happening during the hospital stay, because patients are coming to hospital with some other problem, with some other diagnosis, and pressure ulcers mostly happens during the hospital stay. Like neglected patients in the community or in the house who don't have adequate support, it is again quite understandable. But when it happens in the hospital where there is like trained professionals, it is not something, it shouldn't be something happening. And how to prevent the pressure ulcers, we already discussed it today, I think. And then does pressure ulcers delay the reintegration of patients to community? And what are the effects of wounds or pressure ulcers on quality of the life, and how to manage pressure ulcer or wounds at home? Thank you.
Thank you, Dr. Anit. I'll quickly go through the participants. What do they think? Like, why do you think pressure ulcers happens during the hospital stay? Like, we also get a lot of referrals even with short hospital stay, they come with big pressure ulcers. So any response from the participants? People who are, I know people who are working in ICUs, or what could be the reason? And do you think it will delay?
They may not be taking proper action for preventive measures. They are concentrating more on the treatment part. That might be one of the reasons. Initial prevention should be done.
Yeah, Dr. Bikram is also telling patient factors, disease, and poor care. Yes, they are immobilized and on bed for a longer time. But I think in many places they have this protocol for changing the position and skin care. But then, like, there are so many patients, and as Dr. Shetty said, the priorities, like, they come with a life-threatening situation, and so maybe the priority changes then. Because we also get a lot of, so Sister Sheeba preaches a lot about prevention of bed sores in hospitals, because it's completely preventable. And once you have the bed sore, when it goes to stage 3 or 4, it's very, very difficult to heal. And it is, as you said, in this patient, people go into depression, and then they can't go home for a long period of time. The expense involved and the caregiver burden, everything changes with just one pressure sore, and which is completely preventable. Dr. Priyanka is telling changing the posture, care for skin, and explain at least to the attenders. Any other comments before we ask Sister Sheeba? Yeah. Yes, Dr. Bikram, I totally agree. It completely depends on good nursing care. We have a lot of patients with pressure ulcers, just got discharged from hospital, and they come to us, or they are in the community, unable to do anything at home. So as she was mentioning in the presentation, many a times we cannot afford any surgical intervention. Most of them cannot afford any surgical intervention. So it will take months or years to heal. Sometimes it doesn't heal at all. Over to you, Sister Sheeba, like especially the questions on, will it delay reintegration of patients to the community, or how to manage at home management? I think she covered during the presentation. Over to you for your comments.
Okay. First of all, I'd like to thank you, Dr. Anit, for the excellent presentation. So you did a good job for that patient. And so again, coming to the discussion points questions, maybe I would say because of that lack of nursing care, so only the cause of pressure ulcer formation in the hospital. So we call it as HAPU, hospital acquired pressure ulcer. So this is not maybe because of poor nursing care, but we have I had a similar experience in Pallium, India. I have shared that history with you. So we have a halfway home, and in 2014 we bring the paraplegic patients here, and we used to train the patient. As you mentioned earlier, we when they come here, they don't know how to get out of the bed independently. They always seek support from the caregivers. Our idea is to that move the patient independently. So when they come with the family, so we train the patient as much as possible without depending others. They used to come out from the bed, and they have to take from get out from the bed without support to the support from the bed to wheelchair, and from wheelchair to bed. So and also so that was our idea behind the halfway home. So we have that in 2014, we have around 4 patients with family. So our nurses were changing the positions, were putting the air mattress and all things. They're providing wrinkle-free bed and all. So even then, that 4 patients had developed the pressure ulcer. So they tried to identify the cause, why they developed pressure ulcer. Then we realized that their lack of protein intake in their diet, there is a main reason for the cause of pressure ulcer formation. Then we have developed food, that chart, and then how to what are the menu chart and all. So then we gave a proper instruction to the caregivers and the patient about the importance of nutrition and hydration. Then the pressure sore subside. After that, there is no pressure sore. When the patients come here, we used to talk, teach them about the importance of that nutrition. So maybe this is one of the cause, I would say.
And not only that, now when patient get admitted in the hospital, most of the time they are admitted with some emergency condition, whatever it is. The patient will be on some antibiotics or steroids. So these drugs also can decrease their immunity. Even if the patient is diabetic or anemic, these are the aggravating factor for this sort of ulcer.
That I don't know. So maybe drugs. I don't have any idea about that. So, but within the hospital, maybe because of the lack of protein in their diet and the poor nursing care. So if they are not changing the position 2 to 4 hours early, there is a chance of developing pressure ulcer. And the another thing is not put any air mattress or not. And the next thing is wrinkle-free wrinkles. If there is any wrinkles in the bed, can cause pressure ulcer. And also if there is a nails. So nails there that patients can scratch on their own skin, and then if there is a peeling there, can develop pressure ulcer. Because within the hospital, if the patients can develop pressure ulcer, can cause I would say poor nursing care. And also we can always think about the nutrition and hydration about the patient for prevention.
Thank you, Sister Sheeba. I echo her thoughts because skincare is very, very important and position change. In my family itself, people who had these issues and all those skin medications were given to them, which were really expensive, nothing worked. I just gave liquid paraffin or petroleum jelly, which is the cheapest thing available in the market. It doesn't look quite good. It's a very simple thing, but it just, the skin problems completely disappear. It hardly costs 10-15 rupees for one bottle, and it just keeps the skin so moist and you can change the difference within few days itself. And the position change, and as she mentioned, caregiver, the integration in the community is definitely affected during when you have bed sore, because they don't know how to take care of at home. They sometimes take the patient to hospital, or they pay for a nurse to come home and do the dressing, and they pay a lot every day, 500 600 rupees just for dressing. So we have to give them the confidence to do the dressing at home with the cheapest possible measure, and it doesn't cost much. Like whatever she mentioned in the presentation, these are all the cheapest way that you can manage at home. And even in the IP, we follow the same thing. We make our own saline, we make our own dressings. We don't buy any sterilized fancy dressings. It's the same that we follow in the inpatient unit, and it works like magic. And there are a lot of new therapies coming up with the vacuum therapy, the vac therapy, where they put vacuum with the suction thing. We have done under the supervision of a surgeon, and it worked really well. It brings up granulation tissues, but we have not done that in any home care setting or anything on our own. But educating the caregiver is the key, and making the patient understand. I still remember a patient who started developing suicidal thoughts because he took a picture. The bed sores were on the back. Somehow he took his mobile phone and took a picture of the wound. The wound was clean. The wound was red with good granulation tissue, but that red color scared him. When they see the red color, it just scares them. They don't understand it's a healthy healing wound. So seeing that red big wound, he totally got depressed. He stopped talking. He had all the suicidal thoughts. He lost interest in everything. Then we had to actually start him on antidepressants. So it's very important to educate the patient as well as the caregiver about the stage. And this is like I always say, it's red, it is good, it's healing. So they'll understand. Otherwise, they just get scared seeing the red colored wound, thinking that they are going to die bleeding. I'll just check a question in the chat. Sister Sheeba, you have any experience with Dr. Ravi? Can you just tell what's the use all dressing has? Like, what is the content in that? We have not used it. Can you unmute?
No, I have heard from someone, and details I haven't known. I have heard someone use all dressing can be used. I haven't used. I have no experience with that. I have just listened. Yeah, the dressing name. I thought anything more can be added. What regard your experience?
Okay.
Ma'am, actually, we use all dressings for some patients here. Basically, it's an acronym. It stands for like Edinburgh University Solution of Lyme. So it is helpful in patients who have very active, like a slough or like slough. Basically, takes off the slough, helps in removing the slough. It is available in the hospital pharmacies.
Okay. We don't have experience.
Yes. Thank you. Thank you.
Okay, it's chlorinated lime and boric acid. Okay. No, we don't have any experience in that.
I would like to know one thing, like all these spinal cord patients, like do you also refer to a PMR specialist? Because in Kerala, I think in most of the government colleges, PMR departments are there, which is like, I think in other states, it's not much. Kerala and Tamil Nadu, in most of the places, PMR is there. Even in from a general hospital level itself, especially in Kerala, PMR is there. So do you involve PMR specialists also in rehabilitating patients, especially with spinal cord injury?
Yes, yes, we do have a physical medicine doctor volunteering with us. So he's the one, he does home care once a week. And as Sister Sheeba was mentioning, there is a halfway home project where we rehabilitate spinal cord injury patients before they go back home. It's like halfway home, literally, not directly from hospital. They come here and then they learn all this and go home, which is actually led by the physical medicine rehab doctor. We definitely need a lot of inputs from them. We are just doing a course for physiotherapists, thinking that more of them will come to palliative care and understand. But yeah, we do work very closely with physical medicine rehab team.
Okay.
I think if there are no other questions, 6:34, we can wind up today's session. Thank you so much, Sister Sheeba, for the wonderful session as always. And thank you everyone for the interaction and the questions. And thank you, Dr. Anit, for the wonderful presentation. Shreepriya.
Thank you, Sister Sheeba, for joining us. We do understand your busy schedule with a lot of online, on-site training going on, and still you found time out for the online participants. Thank you so much. And with that note, this is Sri Priya along with Sister Sheeba and Dr. Sridevi Warrior signing off from the Tips Eco Hub. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, stay safe. Take care. Bye-bye.
Thank you.